any institution for biopsy. So having said that, it means that the numbers that we have are actually a tip of the iceberg. Of these 7,165 recorded cases, the majority are females, accounting for 57.6%. And this has been consistent over the years. We always hover around 56, sometimes to 58, 59%, with females being the majority of cancer patients in Zimbabwe. Right, so when we look at the cancers in Zim, cervical cancer is by far the commonest. If you can see the purple line, I don't know if you can see my marker right at the top. So that's 34.8% of all the cancers affecting women in Zimbabwe. One cancer accounts for all of them. That's cervical cancer. Coming next is breast cancer, then non-Hodgkin's lymphoma, and Kaposi sarcoma. Of note with all these cancers, especially the top 5 cancers, when you look at cancer of the cervix, non-Hodgkin's lymphoma, Kaposi, and esophageal cancer, I have skipped breast. These particular cancers that I have mentioned have some link with HIV. So that has been the driver of some of the cancers in Zimbabwe. So looking at specifically cervical cancer, you find that there's a 50% chance that any woman with cervical cancer might have HIV. It's not 100%, but it's a 50-50 situation. But because of the burden of HIV that we have, where we've got the highest prevalence of HIV in sub-Saharan Africa, you find that the sub-Saharan African region has the highest rates of cervical cancer as well, because HIV is permissive to acquiring an infection called HPV, which results in cervical cancer. I'll delve a bit into HPV a bit later. So what is the cervix, or where is the cervix? That's the question you had asked. So the cervix is the lowermost part of the uterus. If you can see my cursor, right at the bottom of the uterus. So if you remember the female anatomy, you've got the ovaries, which are the eggs, and then you've got the fallopian tubes, which are the conduits which carry the eggs from the ovaries all the way up into the actual uterus. And when a woman has intercourse, then that egg will be fertilized in the uterus and then they fall pregnant. If they don't fall pregnant, they'll then have their menses and they'll shed off those ova and they go out through the cervix, which is the opening of the uterus. So in terms of cervical cancer refers to an abnormal proliferation of growth, which starts at that cervix. So if cancer starts in the vagina, it's vaginal cancer. If it starts in the cervix, it's cervical cancer. If it starts in the ovary, it's ovarian cancer. So cervical cancer refers to an abnormal proliferation of growth, which is the ability to invade surrounding tissues, spread to distant organs, and might kill the host, originating from the cervix. Okay. So who gets cervical cancer? Any woman can get cervical cancer, especially if they're sexually active. The main driver of cervical cancer, as I had mentioned earlier on, is the human papillomavirus, particularly type 16 and type 18, where together they account for up to 75% of all the cervical cancers. And about 99% of women with cervical cancer will test positive for HPV. Okay. Some of the drivers which will fuel or exacerbate the prevalence of cervical cancer include multiparity, which is having many children. In the process of delivery, a woman can injure the cervix and make it susceptible to oncogenesis, or the process of abnormal proliferation. Low socioeconomic class, this tends to expose young women to early sexual intercourse. And when you have early sexual intercourse, the probability of having HPV in the cervix and then being unable to clear it is much higher. So coitus at a young age, less than 16 years, coitus is just a fancy word of saying sex. At a young age, less than 16 years, really increases a woman's chance of having cervical cancer later on in life. And then multiple sexual partners. When you've got multiple sexual partners, the probability that one of them will have HPV and pass it on to you will be very, very high. Then immunosuppression, like I spoke about HIV as an example. Women who are HIV positive are likely to get cervical cancer at a much higher rate than women who are HIV negative, because immunosuppression reduces the body's ability to detect abnormal cells, to clear off the abnormal cells, or even to fight off any cancerous cells in the any phases of it. And then smoking. Right. So for cervical cancer, there are ways of trying to prevent it. So there's primary prevention, secondary prevention, and tertiary prevention. Primary prevention, we are mainly looking at immunization against HPV. In this particular instance, we are saying before a woman is even exposed to the causative agent, before they've got any exposure to the HPV, how can we ensure that they never get the cancer? So the best way is to prevent them acquiring HPV. And the best way of doing this has been shown that vaccination is the way to go. So many countries have started vaccinating young girls, including Zimbabwe, where we're targeting girls between the age of 8 and 12. And the program has been enrolled. Initially, there was a pilot project, and then now it's being enrolled to all girls. Having said that, it doesn't mean that a girl who's much older than that age cannot get vaccinated. They can, but then for the purpose of the national program, they targeted a particular age group. Even older women can also have access to HPV vaccination. So as part of primary prevention, we'll also have other interventions like sexual education, tailored to age and culture, where you're encouraging young girls to avoid being sexually active at a very tender age, especially the age where we are saying their cervix is at risk of HPV infection. And then we encourage condom use or condom provision for those who are sexually active. And we also encourage male circumcision, because it's been shown that a male who's circumcised has a less likelihood of harboring HPV than a male who's uncircumcised. And then, of course, the health information about tobacco use and its relationship to cancer. So in 2009, WHO published a paper on HPV vaccination. And through that paper, we realized that HPV vaccination became a public health priority. And within Zimbabwe, participated in making it feasible to vaccinate our young girls. HPV vaccines, which vaccines are there? There are two types of vaccines which are locally available, but in the public sector, we mainly use the bivalent vaccine, which is Cervarix, and it targets HPV 16 and HPV type 18. However, we've got to remember, like I said before, that up to 25 to 30% of cervical lesions can be caused by other HPVs, which are not type 16 and type 18. So you realize that in future, we may need to expand our vaccine type, okay? The other type is called Gardasil, and this is a quadrivalent, meaning that it's got 4 types of HPVs that it works against: the type 16, the type 18, and also the type 6 and the type 11. For HIV-infected persons, I always mention that as an area of interest, because we are in Zimbabwe, we're in sub-Saharan Africa, and HIV is a real reality in our community. So it's been shown that even for HIV-infected persons, HPV vaccine is safe and can also be immunogenic with a long duration, okay? So currently, most cervical cancer screening services are mainly in the urban areas, both in private and in public, but we are trying by all means to decentralize these services to the marginalized rural women. But as we all know that for most of our rural women, they find services either at the district hospital as the first like referral point of care. So we still have some work to do in terms of decentralizing services right up to the rural health center. But of course, they come with challenges regards vaccine safety and storage in some of these very, very remote areas. Secondary prevention. Now, secondary prevention, we are saying a girl or a woman has been possibly exposed to HPV already. So how then do we stop the process of HPV, or how do we detect early that they have HPV and then stop that process of oncogenesis or formation of cancer? So traditionally, we've always used the pap smear, where you take a sample from the cervix and then it's sent to the lab. And really this works. But there are also other methods like the VIAC, which is a visual inspection with acetic acid or iodine of the cervix. And when you find anything abnormal, you then can proceed with other interventions like cryotherapy. HPV testing is also another way that has been found to be a screening tool and can help in terms of early diagnosis. So a woman who's tested for HPV and is positive for type 16 and 18 will then definitely need further management. So the pap test, as you can see, that is the same picture that I showed you of the uterus with the cervix at the bottom. So you put in this metal probe whilst the woman is in a lying position with legs up. So when you put in this metal probe, you then open up that probe. That probe is the speculum. And when you open it up, you then insert a little wire that has got a brush at the end. And then you can take a sample from the outside of the cervix and also from the inner aspect of the cervical canal. This is then rubbed onto a glass slide and then sent to the lab for microscopy. And then the results can be interpreted by pathologists and they are sent back to us, normally within a week. So who needs a pap test or who needs screening? It's any woman who's above the age of 21. Yes, you heard me right, 21. As long as you're sexually active or have been sexually active, you need to get either a pap smear or VIAC done from the age of 21 onwards. Normally, we'll then say if the first or second results are normal, you can then proceed to have those tests every 2 years. However, if you're HIV positive, you may need to have more frequent tests, and we recommend that women go for annual testing. So for VIAC, these are just pictures of what a normal cervix would look like. It will be pink right through, but then when there is cervical dysplasia, which is the early part of cancer formation, there will be acetal white lesions, like the parts of the cervix will turn white, and that is what we'll be looking for when you do a VIAC. How can a woman suspect that she might have cancer? Essentially, there are early symptoms and late symptoms. But what I would want everybody to know out there is that, sadly, cervical cancer is usually asymptomatic in its very early stage. And unfortunately, most African women, we all wait until we have pain or we have discharge or we have a problem to go and seek for help. And with cancer, by the time that you've got a problem or a symptom, often it's a sign that it's actually a little bit advanced or sometimes a lot advanced. So essentially what I'm saying is that for most women, especially if you're going to target stage 1 or even stage 2, they're usually asymptomatic. They have no complaints, nothing at all. So for the even earlier stages, which are pre-malignant before they're even stage 1, these are the ones which are found on screening. But here in Zimbabwe, we find that our screening actually ends up being early diagnosis, in that we are not actually screening and finding pre-malignant conditions. We are screening women, but in the process, we are finding very huge lesions, sometimes up to 3 or 4 centimeters with bleeding, with vaginal discharge. And normally women who come for screening are actually coming because they have noticed that when they have intercourse with their husband or with their partner, they've got what we call postcoital bleeding, or they're having intermenstrual bleeding, meaning that in between their menstrual periods or menstrual cycles, they are spotting or passing some blood abnormally from the vagina. And then some women will also present with post-menopausal bleeding. What this means is they have completely finished their periods and they had stopped for some time, maybe from the age of 50, thereabout going on. But later on, they start noticing that they've got abnormal vaginal bleeding. So these are some of the early symptoms. It's got pain, normally that's a late symptom. Some will present with signs of renal failure, so they'll have edema or swelling of the legs, puffiness of the face, generalized body weakness, loss of weight, loss of appetite, vomiting. Some will come with signs of anemia, so they're just generally weak because they've lost lots of blood. Some will even present with metastasis. Metastasis refers to when the cancer has spread to distant organs. So some women will come for the very first time complaining of backache. So they will say, "Doc, I've got backache." And then when you actually examine, then you realize, they've got backache. It's pain along the spine. Then you do a vaginal examination, and lo and behold, a woman has got a huge fungating cervical mass, which is friable. You take a biopsy, and then it turns out to be cervical cancer. So cervical cancer has got stages. This is just a simplified diagram. Stage 1 is confined to the cervix itself, okay? And stage 2 is spread a little bit beyond the actual cervix. It will be touching the surrounding tissues, which should be the parametrium, or involving part of the vagina, the upper third of the vagina. Stage 3 is when it's now extending all the way from the cervix to the parametrium, to the surrounding tissue, and even going all the way to the bone of the pelvic girdle. If you know that there's that bone which forms your hips, cervical cancer can reach all the way there. And also, if it's spreading down the vagina, sometimes the mass will reach right all the way to the opening of the vagina. And then stage 4 is when we now have metastasis. Like I alluded to, it can spread to distant organs. So it can go to the liver, to the lung, for some women, to the spine, to the bones. And in a few cases, I've seen women where it even goes to the brain. Okay. So how do we manage cervical cancer? Is it manageable? Is it treatable? Yes. The answer is yes. Cervical cancer is one of the most treatable diseases. And it's one of the cancers that I feel that we should not let our women die from. In the early stages, just a simple cervical colonization can actually treat that woman, and then we are rid of any abnormal cells, and we stop the progression from pre-invasive to invasive or cancerous stage. For early stage, stage 1, sometimes women just get a hysterectomy, which is removal of the cervix together with the whole uterus and some of the surrounding lymph nodes. And for some women, that is curative and it's enough. When you go now from stage 1B up to stage 3B, or let's say 4A, you can use radiotherapy as the mainstay of treatment. We then add a little bit of chemotherapy to make the radiation more potent, and we achieve, for some women, complete eradication, for some a long-term control of even up to 5 or even 10 years without any recurrence occurring. So I'm sure as you are listening, I'm thinking, yes, it is possible and it's actually doable. And these services are readily available here in Zimbabwe, both in the public sector and in the private sector. Okay, of course, we've had problems with radiation machines, and I know people will be thinking, yes, we've had problems with radiation machines, but what I'm simply trying to say is at least the machines are available, and when they are working, we are able to actually treat our women. And the chemotherapies are available, and the expertise is also available. For stage 4, we normally often prefer to use chemotherapy as it goes around as the blood is circulating. then it kills cancer cells in the different parts of the body. However, when a woman comes in extremely late, maybe the liver is no longer working, the kidneys are no longer working, in that particular scenario, we just give best supportive care. What this means is if they're in pain, we manage the pain. If they are bleeding, we attend to the bleeding. If they've got a foul smelling infective discharge, we deal with the infection. So overall, you realize that when a woman presents early stage 1, they've got an 80 to 90% chance of beating the cancer. Compared to when a woman presents in stage 4, they only have got a 4% maximum chance of remotely controlling the cancer. So early detection does save lives. And I would encourage women to try not to wait until things are out of control. Most of our women in Zimbabwe present with stage 3 and stage 4 disease, which means that they are presenting with less than a 50% chance of control. So that is a very, very sad situation. It would be better if women present earlier, or I think I might have a problem with my laptop. If it shuts down, then we'll move to another device. I'll just log in another device. But all I was going to say is that I would encourage that our women present early, or better still, we even avoid them coming in at stage 1 or stage 2. They come in for screening, we catch the pre-malignant lesions, and they never even have to have the cancer at all. So remember that most cervical cancers can be prevented if women have regular pap tests with them and follow up of any abnormal changes. Okay, so I think we've reached the end of our presentation. Any questions?
Wow, quite informative, Doc. Thank you very much. I had a lot of questions and you have essentially answered most of them, most of the questions that I had. And you mentioned something about having HPV vaccine for the ages of 8 to 12 young girls in Zimbabwe, and then those that can go for screening, you start from the age of 21. So is there anything that is for the young girls between the ages of 12 and 21? Which side do they go to? Do they go for the screening side or to the vaccine side?
So if they've not been vaccinated, they can go to the vaccination side. Because vaccination, remember that when you've got a national program, we are not saying that it precludes any other girl or any other woman, but we are saying that for a vaccination program, by the time that a woman has got cancer, they probably have been exposed 5 to 10 years prior. So if we feel that 21 is the age we are starting to screen, we'll then go back so many years to a point where we want to catch them before they actually have these pre-malignant lesions. Sorry, I'm getting feedback. Dr. S, can you deal with this? Hello, can you hear me? Hello, can you hear me?
Yes, we can.
Sorry, I just had a terrible feedback when I switched on my other device.
Okay.
Yeah, so my laptop is officially off. So I was saying that, so it's not as if that they've been left out, not really. It's just that it's the target for the different things. These are mutually exclusive. They are not related to say, oh, we're doing this for this age group, we're doing this for age group, for this age group. The national screening programs target the most vulnerable group, but then sometimes they also target the group that will give you the best results. So we are saying that perhaps by the time that a girl is 18, they might have been exposed to HPV already and already sexually active. So in that regard, we might as well wait for them to start screening at a later age.
Oh, okay. So essentially, no one is left behind. Everyone is getting part of the preventive measures. Thank you. And
Yes.
I'm interested to know on part of feminine vaginal watch, or what would it be any risk factor in getting cervical cancer?
Yes, so if a woman has got vaginal warts are caused by HPV. However, we generally say that the type of HPV that causes vaginal warts tend to be type 6 and type 11, which are non-cancerous. Having said that, if a woman has got vaginal warts, the chances of them having HPV 6 and 11 is very high, but it means that they can also have the cancerous HPV subtypes. So we encourage women to actually go and get checked, and preferably even get those warts cauterized, that is treated and removed. The sad thing as well is that some warts can actually harbor malignant or pre-malignant lesions, which are cancerous and can eventually allow a cancer to happen. So when a woman has got warts, we actually get worried and we say they should just go and get it treated.
Okay, thank you, Doc. And what would you say about, especially now in this era, in our generation, young girls are using different stuff to wash their vaginas and everything. I think they call it douching. I'm not sure of the spelling or the pronunciation. Are they susceptible to cervical cancer?
Yes, so douching has been a very controversial practice, and you find that from region to region, women use different materials to douch. Some will douch because they want their cervixes to be drier. Some will do it for sexual pleasure. Some will do it because it's part of their culture or tradition. Having said that, we are aware that some of the materials used in douching can actually go and irritate the cervix and therefore trigger abnormal cells to proliferate. There have not been huge studies looking at young girls who are douching to actually we've got huge studies which are proving this or that, but we've seen that statistically it seems that there's a relatively higher number of girls who seem to eventually have problems, or the ones who have problems as women. Some of them have got a history of having been using either herbs or whatever materials for douching. So if possible, we discourage girls from douching or putting anything abnormal inside their vaginas.
Oh, okay. Quite a lot. And you mentioned about the treatment modalities and management for cancer patients that are available here in Zimbabwe. And what would you tell to a caregiver, someone who is taking care of cervical cancer patients? Half the time we concentrate on the cervical cancer patients, but then there are people who are taking care of those people. And sometimes they really do not know what to do, how to handle themselves, how to handle the situation. What can you tell to caregivers of cervical cancer patients?
Right. So really, in terms of taking care of cervical cancer patients, the first thing is to remember that they are chronically unwell. What this means is they are suffering from an illness which might take quite a while before it's completely dealt with or completely cleared away. So it's not an illness that you say, oh, I had a flu for 2 days and it's gone, right? So that's step number one. Number two, the patient undergoes different phases. First, they have to be told this news that they've got cancer, and that's bad news. It's not good to be told that you've got cancer. Whichever way you look at it, it is some form of bad news. So when somebody has been told bad news, they'll go through sadness, then they'll go through denial, then they'll go through anger, then eventually they'll get to acceptance. So all these are phases where ideally it would be nice if they go through with somebody who understands what they're going through and is holding their hand. And then the other thing that caregivers should remember is people have got different stages of cancer. So simply because a caregiver knows patient X who had cervical cancer and perhaps succumbed to it, does not mean that patient will through the same outcome. So we've got to remember to speak to our patients in view of all this, because sometimes caregivers then talk about other patients who died and all this, and then you make the current patient whom you have lose hope. So at the end of the day, we've got to remember to always be sensitive about what we say and give hope to our patients, and know that each patient is an individual. They may respond differently to treatment. If you look at malaria treatments, for example, one patient will respond very well to Coartem, another will not, they'll need to be admitted. These are differences, but you cannot go about saying, oh, because so-and-so was admitted and they had very bad malaria, ended up having cerebral malaria, or they even died. Therefore, nobody should be treated of malaria because they will die. It's just an example. So all I'm saying is we've got to remember to be very sensitive to our patients, to encourage them. And sometimes when we ourselves have got issues, it's better to discuss them when we are far from our patient. The other thing that I want caregivers to remember is they themselves sometimes need help. Yes, it's not easy to take care of a patient with cancer. Sometimes they go through anger, so they can vent their frustrations on their caregiver. And some people will say, I was taking care of my father, I'm taking care of my mom, doc. Now this patient of yours has become very vindictive. They're always accusing me of this. They're ungrateful. It's part of the journey, and sometimes it's part of the process. We just need to have a big heart for us to be able to cope with all this.
All right, Doc. I'm checking in the chat box, and looks like we do not have any other questions coming. Yes, there aren't any other questions. If there's anyone who has a question, please just put it in the chat box. But maybe my last question to you, Doc, would be, you mentioned about screening and how it is a very vital thing in terms of preventing cervical cancer. In Harare and probably in other major cities, where can people go for screening, and is it free? Yeah, perhaps if there's anyone who would want to go for screening, where can they go, and is it free?
So in Harare, there are many centers, like I had also alluded to. There are also centers scattered right around most urban centers, because the government has tried to equip most of the district hospitals, provincial hospitals, and central hospitals with screening services, particularly the VIA program. So generally, yes, people can get access to screening. However, in most centers, it's not free, because there are consumables which are used, and then ends up attracting some kind of a fee, but it is not prohibitive. I'm looking at, for example, Spielhaus. Previously, they used to charge about $20. I'm not sure what exactly the current figure would be right now with our economy and RTGS and all these different values that we have, but they actually do offer screening, and they try to make it as accessible as possible to most women. Private sector also offers screening services, and for most centers, it is not for free, but we tend to then say, for example, during the October month, there are slashed prices. Sometimes we even do free cancer screening drives. Why it's difficult to maintain a free, completely free service throughout, because like we alluded to, we saw that there are things which have to be used, they are speculum, they have to be sterilized, and all those things still fall back onto the private centers. Having said that, I think that there's still room and scope for partners coming in, raising funds, and together with the specialists and the doctors working together to give some form of free service at some intervals to our less privileged women, especially in the villages. The guys in town, I think perhaps they'll be able to get $5, $10 to pay for their screening, but there are some women who can't afford it all, and these ones are also being left out. So yeah, those are our services which are available. Once in a while, a person can just hang on for a free cancer screening in October, or for example, this past January, at Cancer Health Clinic, we had a few
Okay, can you hear me?
Maybe I would like to ask a question to Women Healing Foundation.
Yes, Doc.
Hello?
Yes, Doc. Hello?
Would there be any scope or possibility of Women Healing Foundation being actively involved and supporting some of these services to a point where they can be free or nearly free for some women?
Doc, my network tripped. I didn't get the question.
Saying, is there any scope or possibility of Women Healing Foundation being involved in supporting some of these services so that they end up free or nearly free for some women?
Oh, okay. Definitely. That's our main motive actually for having some of the health facilities being available for people, especially for marginalized communities. However, we might not be able to do that financially, but we can do it in other ways. For example, advocating to other organizations that we know that will be able to chip in, being mediators to probably other organizations that we know might be able to help them. We could also do that in form of education and just raising awareness, because most people probably they do not go just because they don't know that it's actually a need for them to be doing certain things. And we feel that maybe just by doing those things, advocacy, education, raising awareness, it could probably help in a way. And maybe in the future, when we are able to do it financially, then yes, definitely we might be able to help.
Okay. Okay. Yeah, because for this year as World Cancer Community, the theme for the World Cancer Day for 2022 was closing the gap. So essentially, we are trying by all means as the oncology community to say, how best can we close the gap regards provision of service, access to care, and even the knowledge gap. There are so many gaps, and sometimes our people will perish because they've got no idea that there is a cervix and that it can become cancerous, and that this cervical cancer is the leading cancer amongst women in this Zimbabwe which they live in. So you're right to say that sometimes education does play an important part in terms of access.
Yeah, true. And also it it's Cancer Health Clinic. At Cancer Health Clinic, are there any services that are offered also for cervical cancer?
Yes. So at Cancer Health Clinic, we actually offer cervical cancer screening, and we prefer to use the pap smear because we feel that it is the gold standard internationally, but we also do encourage women to also go for VIAC at other centers. And at Cancer Health Clinic, we also have health education workshops. For example, in the month of January, where we just passed, it was Cervical Cancer Month, we had cervical cancer patient survivors come together, talk about their journey, encouraging other women who had been recently diagnosed, and then just celebrating the fact that they had actually managed to overcome this disease. But having said that, we've had outreach programs, and we are still planning to have more outreach programs in the year of 2022. I'm sure we met at Masawara, where we're having a cancer outreach, just giving public education about cancer, and talking to the village women, just to let them know that they should have their VIAC done. And funny enough, even though we feel that, oh, maybe the village women will not understand, they actually appreciate the services more, and they stick to their annual VIAC, sometimes even more than the urbanized women. And Chitungwiza, we had a very great outreach in 2021, and we are going to be repeating it every year and making it an annual event where we'll be offering free breast examinations and also free VIACs to the women of Chitungwiza and any other women who come to Chitungwiza during the period when we are there. Of course, you then asked what other services we offer cervical cancer treatment as well.
Okay, those are great strides, Doc, and thank you very much for doing. And we have an interesting question in the chat box. Tino Viga asked, Dr. Mba, you mentioned about the HPV vaccine. How well is it being accepted by the public, considering it is a new vaccine being introduced in our country, even though it has been available in other countries for years now?
So our public initially had mixed feelings about the HPV vaccine, but we've had it around for quite a while now, about 4 or 5 years. And initially parents were very skeptical about whether they should get their girls vaccinated or not. But I think the approach which the government used of unrolling it at schools sort of encouraged parents eventually to realize that, okay, it's okay, because what happens with schools is there's that peer pressure where other parents are allowing their girls and others actually benefiting, and then they realize that, okay, the kids got vaccinated and then they didn't fall sick, because the fear with most of the parents is, what if they fall sick? What if they get strange side effects? So this has not been happening, and slowly our people are becoming very comfortable with it. I think the fear actually with new vaccine in our community has been with the new COVID-19 vaccine. The HPV had a bit of resistance, but I think slowly we are getting on the way.
Yeah, true that. Thank you very much, Dr. Mba. This has been very informative. I wasn't thinking we were going to take an hour, but we did. Thank you for sparing time from your busy schedule just to be with us and share with us all the things about cervical cancer. And yeah, sure. If we tend to have any other things, I hope we are open to ask.
Yes, I'm open to you guys. We've met physically, and we can always plan more. For me, it's really more of a passion to want to spread information to all the women of Zimbabwe. You know, it's important that women get empowered and they understand some of these things I believe that knowledge is the first aspect of power. You can act only on something that you understand.
True that. Thank you. We're also going to be taking part in educating, even in the word of God, lack of knowledge. But we thank you very much, Doc, and I think we've reached to the end of our today's session. And to everyone who participated, please let it not just end with us. Let's spread the information out there to those who are not able to log in. Let's also keep the information going. I think this will be the end of our discussion. Thank you, Dr. Mba. We really, really, really appreciate.
Thank you. Be blessed.